The WHO calls it a public health emergency of international concern. So how concerned should you really be about Mpox? We'll hope to find out on today's news desk. I'm Piresh Banerjee.
Yeah, and I am Alex Forrest-Whiting, and I'm going to be looking at all your comments that you put in the chat and bringing them into our discussion, putting them also to our expert a little bit later in the stream.
But first, let's address the most obvious concern that is definitively out there. That question and that concern being, is Mpox the new COVID? Let's listen to what the WHO has to say about that.
Mpox is not the new COVID. Regardless of whether it's Mpox clade 1 behind the ongoing outbreak in East Central Africa or Mpox clade 2 behind the 2022 outbreak that initially impacted Europe and has continued to circulate in Europe since. We know quite a lot about clade 2 already. We still have to learn more about clade 1.
And those are the two strains of the Mpox virus. And you will hear a lot about clade 1 and its subvariant clade 1b throughout these discussions today at the table.
Yes, and talking of the table, let me introduce you to who we have around the table. We have Amian Isif, who is here to my right. He is correspondent, reporter. Great to have you with us. Always good to have you in the stream. And also we have Cherry Chan. You will have already seen Cherry in the chat. She will be making sure that you are staying nice and polite and making sure that she highlights any important points and questions that we can put to our guests and discuss. So
yes, make sure you are polite, otherwise Cherry's wrath will be upon you.
Yeah, you don't want
in the
that.
Community chat. You do not want to have that on you. Anyhow, later we will also have Salim Abdul Karim, who is a professor of global health at Columbia University and also an epidemiologist who is closely connected to this current Mpox outbreak in Africa.
And we have been asking you for your comments, and we had up a community post, which some of you have already commented on. So I'm just going to highlight three of those comments. At Conscious Thought says, there is no reason why in a humane society diseases and illnesses such as this should exist to epidemic proportions. Not Unimus says, what's there to do? Take care, get your shot, your vaccine, and hope for the best. And At the Gamer Boy says, I'm no medical expert, but let's not overreact like we did with COVID. Now, actually, with that comment, there were a lot of replies to that. People upset with that comment, particularly those who said that they had lost ones during COVID. But it is something that we will be talking about a little bit later. And also another comment that was made a few times was about the possible amounts of money that could be made by pharmaceutical companies. Again, we will talk about vaccines and that whole issue a little bit later.
And as you consider what comments to post in that community chat, you might also like to consider answering a poll question that we have prepared for you. And this is where Cherry can introduce you to that poll question.
Yeah, today we have a relatively easy poll question. So the question is, how concerned are you about Mpox? There are four options. Yes, very concerned, a little concerned, not concerned but cautious, or not concerned at all. So don't forget to vote. You will find it on top of the live chat.
And we will have the results later on in the stream. So be sure to vote. It gives us a handle on what it is that you all are thinking and the direction in which you all consider.
I'm curious to see if it's going to change people's mind after they watch the show, if they're more or less worried about the outbreak after the show.
Let's talk about our polls, because our polls in the past, we've begun with a question and we've been surprised by the response in the end. So
definitely,
let's see if the information that you might be providing us in a short while helps people change their mind. Speaking of that, Amian, you can provide us some context on where we are.
I mean, after researching this for a while, I have to say I'm less concerned than I was when I first heard the announcement that there was this new Mpox strain, this new clade going around. I was shocked by that. So I think if people stick around, they might, if they understand the virus a little bit more, then they might feel a bit less concerned, even though it is an outbreak of global concern, as the WHO said. First, I want to address the monkey in the room, the fact that it's not called monkeypox anymore. So some people might feel like, what happened? What is Mpox? Mpox is what was formerly known as monkeypox. Remember the outbreak from 2022? That was a global outbreak. There was, most countries in the world had some cases of it. It was called monkeypox back then, but then November 2023, so late last year, the WHO decided to change the name. A lot of people complaining about the stigma associated with monkeys, and also the fact that it's a misnomer. So this goes into the history of the monkeypox, which I can get into. It's pretty interesting that it was discovered in the 50s, first in Copenhagen, Denmark, in lab monkeys that were imported from Asia. So it has...
From Asia?
Yeah, that's right. Even though the first major outbreaks were in Central Africa, the first discovery of this virus was in a monkey in Denmark that was imported from Asia. And that's why it was called the monkeypox. Back then, it's also an interesting history of virology. Humans were most worried about viruses coming from monkeys because they're closely related to humans. But now things have changed, and we realize that some of the worst viruses are coming from bats and rodents. And actually, the Mpox is most likely, we don't know yet, but it's most likely spread through eating rodents. So it really has very little to do with monkeys, except the fact that it was discovered. It was named by researching monkeys. So that's why they've changed the name. So hopefully we can all, I think Mpox is just shorter and easier. And
easier to say.
Yeah, so we're sticking to that. So what is this virus? It's actually closely related to smallpox. That's something I've heard about since I was a kid. It was really one of the worst viruses ever to hit the world, killed 30% of the people that were infected by it, but luckily that's not the case with Mpox. You can see, I can share this picture, it's too close, of what the virus looks like under an electron microscope. These are the cells. It's been colorized for effect. It looks quite a bit like smallpox under the microscope. And now, trigger warning, I'm sure some of you guys have already seen this before, but this is what monkeypox looks like on somebody's skin. So if you're sensitive, you can look away, but you probably see the images anywhere. Anyway, it's not that bad in this picture. But yeah, it's a pox virus that creates these blisters on people's skin. It starts out as a fever and then a rash, and then it turns into this blistery infection. The vast majority of people who catch the virus, this is the worst it gets. They go away, they might leave scars, but otherwise most people recover. We don't know exactly how many people are dying from this virus. That still needs to be researched. The time that most people, in my generation anyway, heard of Mpox was the 2022 outbreak. So a couple of years ago, we started to hear of cases leaving Central Africa where it's endemic, meaning they've been getting this virus for a couple of decades now, but it was almost unheard of outside of Central Africa, Eastern and Western Africa as well. And so in 2022, it became a global outbreak. What we saw there, it was mostly sexually transmitted. It was mostly men who were having sex with men who contracted the virus, but it wasn't just that. It's just that this is the main way that that virus from 2022, the Mpox virus, was spreading. That was called clade 2. Now, clade it's like a subvariant, basically. It's a family of a virus. What has gotten the WHO concerned now, and this is why we're talking about it again, even though we're not seeing cases in Europe and the US and in Asia, apart from a few isolated cases, is the fact that there's this new clade 1b, and it has epidemiologists concerned because it's acting in ways that we haven't seen Mpox act before. And that's always scary when viruses are discovered, new viruses, because it doesn't mean, a lot of people in the comments are saying, oh, we're overacting. Well, they've triggered a warning by calling it a outbreak of global concern. They haven't said they know everything about it and that we're all going to have to, they said there's probably not going to be lockdowns, but they don't know that much about it, and that's why they've triggered this warning, because they want to know about it and they want to stop it before it spreads so that they have more time to research.
But it's not the first time that they've issued a warning in relation to Mpox, right? You're talking about 2022, when this thing spread outside of Central Africa, beyond Africa's borders. In 2022 as well, public health emergency of international concern. I think that's the technical classification. That is what was issued by the WHO, right? Right.
And in 2022, the virus was mostly contained. People figured out how it was spreading. People took precautions, and there's still cases outside of Central Africa, but it's been greatly reduced. So you can see here where the first outbreak happened. So you can see the red countries are where the virus had never been before. So you saw India, China, Russia, every country in Europe, North America, South America. And then the blue and purple and pink is where previous to 2022, there were cases of Mpox detected.
Right.
What we're talking about now, and the reason why it's worrying a lot of virologists, is a new outbreak of clade 1b, and that is what we want to talk about today. There's still a lot that's not known about it, but you can see that since this summer, if you can see right here, cases have really spiked. This is in the Democratic Republic of Congo, so DRC, where it is endemic, but this clade is not endemic. So a lot of people are getting it. It was first detected among mining workers,
right.
and the belief there is that it was starting to spread because of sex work, like having sex with sex workers, what their CDC is calling transactional sex. So it's spreading among this community, but it has escaped that community. And now there are signs that it's not just sexually transmitted. A lot of children are getting it, especially in this one refugee camp in Goma, also in the Congo, that people are getting it without having sex, so
right.
they believe that it's being spread by close contact. That's worrying to people, because if there's a sexually transmitted disease going around, you can make sure you don't get it by not having sex or having
right.
protected sex or testing your partner before you have sex. But if it's spread by close contact, you have to cut off contact with anybody, like we saw with COVID. And that's why people are relating it to COVID. Now, it's not anywhere nearly as transmissible as COVID was. In COVID, you saw, that's what was so crazy about it.
Yeah.
One person in a room with 100 people could give 100 people COVID, whereas this doesn't seem to be spreading anywhere near that fast. But it is concerning that it's spreading in ways that we haven't seen Mpox spread before. About 20,000 cases of this latest outbreak have been reported, mostly in the DRC, and I've seen numbers as high as over 500 deaths, most of them related to the outbreak in the DRC. And the last thing I'll say about this is that this is basically 3 outbreaks at once. It's the clade 1b, which we're going to be getting into today. That's most worrying. It's the CDC has.
That's the most recent outbreak.
That's the most recent outbreak.
Yeah.
That's this one that has is spreading in ways that we haven't seen the virus spread before. But there's also clade 2 and clade 1a that are simultaneously spreading. So you have the same virus from the 2022 outbreak, plus this clade 1, which has been endemic, clade 1a, which has been endemic in Central, Eastern, and Western Africa for a while now, plus this new clade that we haven't seen before. So they're all 3 happening at the same time. The question is why? I think that's also really interesting to get into. It has a lot to do with the fact
And we want to get into
smallpox
that with our guest.
The smallpox is not, they're not vaccinating against smallpox anymore because we eradicated it with vaccines. So that's a great thing to bring up when we talk about vaccines.
Thanks for that, Amien. And as Amien was saying, we do want to talk about vaccines. Just stay with us. There are lots of questions that you all will have about that. That is going to come up. But let's just bring in our expert who can help us clarify some of these, answer some of these questions that Amien was raising, that you guys are raising in the chat. Let's bring in Salim Abdul Karim. He's a professor of global health at Columbia University, and he's also an epidemiologist. He was also the man who was the chair of the Africa CDC meeting that declared this an outbreak on the continent. We're so glad that you've been able to make time for us, Professor Karim. Thanks so much for joining us. Before we get into the nitty-gritty of the Mpox virus, I just thought we'd like to play a soundbite from the chair of the WHO's Mpox Emergency Committee. He was speaking to the press. Let's listen to what he said just a few days earlier. Let's play that now.
We are still working blindly in Africa. We don't have the required knowledge about Mpox, natural history, transmission dynamics, risk factors of Mpox, and essentially you need to understand your context. You need to understand your disease for you to develop or design preventive strategies against such a disease. And that's a significant limitation. And that tells us that we need to invest in uncovering, understanding our disease better.
Professor Karim, do we understand this disease? Are we flying in the dark?
My apologies, I was muted. No, so There is quite a lot that we do know about Mpox. It's a disease that we've seen sporadic outbreaks of. It's a disease we know clinically how to diagnose. It's a disease for which we have a diagnostic. It's a disease for which we have a vaccine. So we're not entirely flying in the dark. I think what he's referring to is that what we know at this point is just the tip of the iceberg. And the main challenge we have is that the situation in the DRC, which is where we are most concerned about this outbreak, is in a situation of pretty much warfare. Government soldiers are fighting with rebels. We have a situation where the healthcare system is under huge stress. And for example, many of our patients with Mpox in the DRC, we don't have a laboratory diagnosis on them because we can't get the specimens to the lab. So there's a lot of challenges that we're dealing with in the DRC that's leading to a situation where we don't have the full picture. But we do know some things, and of those things we know is at the minimum we have some idea of the cases that are pitching up at the healthcare services, and at those cases the numbers are rising, and you saw that very clearly in the diagram that was just shared with you.
And talking about those numbers, I mean, I think at last count we have something like 22,800 cases shared by the Africa CDC. Given that you just said that you don't have these testing facilities that are required to confirm and make these diagnoses, this number, 22,800, could be way too low and not the real number, correct?
Yeah, so it could go in both directions, actually. So it's very likely that the true number is significantly higher because many of the patients just can't get to the healthcare services and so are not being diagnosed. But on the flip side, it's not difficult to make a diagnosis of Mpox based on the clinical picture that we see with the lesions on the skin. But there is a small chance that you can mix the diagnosis of chickenpox, for example, with Mpox. And that will be mainly in children. And that's probably not occurring to a significant extent. But because of that, we like to have a laboratory diagnosis to confirm that we're actually seeing a case of Mpox. I think that the more likely situation overall is that the numbers we have from the Africa CDC are a significant underestimate of the true numbers in the community.
And if these numbers, assuming, are way higher, let's assume, just an assumption, we don't have final figures yet. If these numbers are way higher, it clearly lends credence to the fact, or what we're hearing, that this is definitely more infectious, this particular variant that Amian was also talking about, clade 1b. Can you help us understand the modes of transmission? How is it spreading and why is it so infectious?
So we know that all viruses mutate and we see new variants. In fact, COVID-19 was a good lesson to all of us about the importance of new variants and that there can be occasions when a new variant is much more efficient in the way in which it causes infection. And so it can be more infectious and lead to a faster spread of the virus. And Omicron was a good example of that. Now, Mpox does not spread like COVID-19. So we don't see, that a kind of explosive spread where, one patient leads to many, many infections. Indeed, generally with Mpox, the infection is a slow spreading infection. One patient leads to another, and you can track the chains of transmission. And so what we are seeing in this particular instance is a new variant of the virus. And you must remember, in the DRC, you've got in different provinces, different clades spreading. So if you take Equateur, there, the predominant clade that's spreading is clade 1A. Whereas if you take South Kivu, which is right on the border with Burundi and with Rwanda, there we have clade 1b that is spreading. So you've got different clades, there's almost sort of independent epidemics occurring. What's occurring with the clade 1b, and that's different from the other clades spreading in the DRC, is that there seems to be a preponderance of sexual transmission. And that was most clear because of the high proportion of cases that were coming forward. At one stage, we had 384 sex workers that were presenting to the healthcare service. So that suggested that what we're seeing in Mpox is not just an infection that spreads through close contact, but one that's quite likely spreading also through sexual transmission. So that's what we're now concerned about as well.
Just a quick clarification, and then we can bring in some comments from the community. Just to clarify, COVID was spreading through droplets and particulates. When you were in the room with somebody, and if somebody talked or sneezed and the particulates extended to about, I don't know, more than a meter, 10 meters, you would potentially get it. That is not happening with Mpox, and physical contact is necessary. Is that what you're saying? Skin-to-skin contact?
Yeah, so I mean, we can't say 100% for sure that there's no droplet spread, and there might be some droplet spread, but it's a very different scenario. In COVID, if you had somebody with the infection and they were, for example, singing in a choir, they would infect large numbers of the people singing with you in the choir, whereas you wouldn't have that kind of scenario in Mpox.
I just have a question myself, and then we've got some questions also in the chat. My question is, if you're talking, saying that it has been spread through sexual activity, why with this particular clade are we seeing that so many children have been affected in the Democratic Republic of Congo?
Okay, so just for context, to understand what we're dealing with. In countries where the population has been vaccinated against smallpox, we are not particularly concerned because smallpox vaccination offers protection against Mpox. And in many countries, where the population is largely elderly, there's no real concern because the proportion that's not vaccinated against smallpox is small. In Africa, the situation is different in that because vaccination against smallpox stopped in the 1970s, everybody below the age of 40 is at risk. And because Africa has this youth dividend, where there's a very high proportion of the population that's young, you now have a very high number of people. And if you take just below age 35, in many African countries, that's over 70% of the population. So now you've got a very high proportion of the population that is young and is not protected through the old smallpox vaccination. And included in that is children. So when you're looking at this clade 1b, you are seeing sexual transmission, but you are also seeing the traditional routes of Mpox spread, which is through close contact. And once it spreads in the children, they play amongst themselves and spread the virus amongst themselves. And so that's why you will see a fairly large number of children. They don't have protection, and they have close contacts amongst each other.
Thank you for clarifying that. And I just want to come back to our chat because there are lots of people asking lots of good questions. This is Mick Osis, who basically is asking what the difference really is between these clades, because they're saying they seem to be closely related, near identical genetically. Is that true?
So when you have a variant, the variant has some changes in the genetic makeup that leads to a functional change that we see clinically or we see epidemiologically. Now, remember, the virus like all viruses, is mutating all the time. But these minor changes that we see, these minor mutations, they don't lead to any significant change in the virus. But every now and then you get a significant amount of changes in the genetics that leads to a different virus. It's exactly the same with all viruses. I mean, if you take, influenza, the virus changes, with small changes that we don't worry too much about. But every now and then we get a big change. And when that big change occurs, then we see that we don't actually have immunity and that virus can spread much faster. So we are seeing something similar right now. So even though most of the genetic material between clade 1b and clade 1 itself is actually the same, the changes that are occurring in a critically important part of the virus. And principally, they are occurring in a part of the virus that deals with ApoB. And because it deals with ApoB, that deals with infectiousness. And when it deals with infectiousness, and that means that this virus can spread a little bit more easily than what we've seen before. And because it has a reproduction advantage, you will see it spreading faster than we saw with the previous variants. So I hope that explains that question.
But does that explain also, Professor, why people are saying that this new variant, 1B particularly, is more deadly? I mean, is it more deadly, or is it that this virus is running in a population that may not have access to the kind of healthcare and the kind of nutrition that is potentially available in other parts of the world? Can you explain that part about it being deadly?
Right. So Mpox has traditionally not been a disease we worry too much about, because the mortality, and what we better still talk about, is the case fatality rate. So the proportion of cases that go on to die is generally quite low. With the clade 2 of the virus, the case fatality rate has generally tended to be under 1%. So when you're thinking about it, it's a very small proportion of patients that will go on to getting a very severe form of the disease and die. In this particular clade 1b, the mortality rate from the data we are seeing from South Kivu is running at closer to around 3%. And that now tells us that we have a 3 times higher chance of dying if you have the infection. Now, there are 2 caveats to that. And the one caveat is that we don't know about all the cases. So it might be that we just know a lot more about the severe cases that are dying. So the actual true value may actually be somewhat lower. But even if it is somewhat lower, it's unlikely that it's as low as what we saw with the clade 2. So that bias does not obviate the concern that there are more people dying once diagnosed with the clade 1b than we saw with clade 2. And the second problem, of course, is that patients might be dying because of the collapse of the healthcare service. And that is hard to quantify. Regardless, we are still concerned that this is much more than we would expect, despite all of the other things that might be influencing it.
I do want to talk to you in detail, if possible, about vaccines, because lots of people in the chat have questions about vaccines, whether that should be happening or not. But before we come to that, Professor, I just want to know from you, we are talking about an outbreak currently. Does this have a potential to transform into a pandemic, a global pandemic of the kind that we saw with COVID? We just emerged from COVID just a year and a half back. So, I cannot not ask you if that is something that we're headed towards again.
So it's unlikely that we would see Mpox take a similar form to what we saw with COVID-19. So I think let's just get that out of the way. a respiratory route transmission is a very different cup of tea. That's what we see in COVID-19. That's what we see in influenza. We will see a very high proportion of the population being exposed, getting infected. It's very, very unlikely we'll see anything along those lines with Mpox. So why are we concerned?
Yeah, so no,
Yes.
in fact, that's a question in the chat from RS. Is it capable? Could there possibly be a lockdown? But you're pretty much saying there no.
Yeah, in fact, I just provided information to Reuters when they were doing a fact check. Actually, for a respiratory spread disease, creating distance between individuals helps in slowing the infection. Mm-hmm. When you're dealing with a sexually transmitted infection, or when you're dealing with one that's in close contact, creating a lockdown has little, if any, effect, because the virus spreads slowly from person to person, and sexual contact is just going to lead to the eventual spread of this virus. So a lockdown has almost no value. So there's no reason to think that we would need to go into a lockdown. Instead, we need to take a completely different approach. And the approach that works quite well... Sorry, I'm interrupting someone.
No, please go ahead. Please go ahead.
So the approach that works very well with Mpox, and in fact, it's an approach we've used in many of our outbreaks in the past in Africa. Remember, we've had outbreaks of Mpox for 50 years in Africa. This is not new. And what works very simply is what we call test, trace, educate. So you test individuals. In other words, you try and increase your case detection. You try and identify as many people as possible. And when you've identified an individual, you've got to trace all their contacts, their sexual contacts, the people they live at home with, all the people they have close contact with. And all of those people need to be educated. They need to be told that these are the symptoms of Mpox. This is how you get diagnosed. This is how you prevent it from spreading to anyone else. Avoid close contact because you are now an exposed individual. So you educate them, and you ensure that they know that if they do get the infection, how to quickly seek care. But also, you're now slowing the spread of the virus because they don't spread it on to others. So test, trace, and educate works quite well. If we had vaccines, we would do test, trace, educate, and vaccinate. So you would vaccinate the ring of individuals who've all been exposed or who are at risk of exposure. You vaccinate them so that you slow the spread of virus to others. In fact, that's what happened in the first public health emergency. Mm-hmm. There was this ring vaccination that slowed the spread of the virus. So vaccination could be an important adjunct in our test, trace, educate intervention plan.
You know, we'll use that as a segue to talk about vaccination. But just before we do, I'd just like to go to Cherry, who's been monitoring the chat that you guys have been posting comments in. Let's get an idea of the mood over there, and then we can talk about vaccination. So, Cherry.
Yeah, so a lot of people, you already asked a question to our expert. A lot of people were worried about lockdown. Carolina Fellini said she was traumatized by the previous lockdown, and so she is really worried, and other people agree also. Also, there are some people who have some other theories about the outbreak of this Mpox. And I'm not going to say these theories because I think they're unfounded, but it just goes to show that people actually know quite little about this Mpox outbreak.
Which is why we have Professor Karim, and we are glad that you are with us, Professor Karim, to help us sort of set things right and inform everybody who's tuning in. Let's talk about vaccines, because that is something that a lot of people want to know things about. Are vaccines the answer? I mean, they were the answer for COVID. Are vaccines the answer for the Mpox outbreak currently?
So right now, vaccines are not the answer. In fact, a vaccine would have very limited benefit if we don't have high case detection. We need to identify cases so we know who to vaccinate. And the reason for that is very simple. that right now there are about 2 to 3 different vaccines that are quite effective against Mpox. But these vaccines are quite expensive. So they cost between $100 to $200 a dose, and you have to give 2 doses to protect somebody. So practically speaking, it's not something we can just give out willy-nilly because of the cost involved. There's also very limited supply. There's only a limited supply, and there are countries that have doses of this vaccine that are hoarding them. They're just not making them available. They're concerned they're going to need them for their own citizens, so they're not making them available to the people in the DRC. And the companies that make these vaccines only have limited supply. So we have to look at what's the best and most judicious use of limited supply of the vaccine. And that's really to follow the same strategy that we used very effectively in smallpox, because Mpox is a relative of smallpox. It's the same strategy. It's referred to as a ring vaccination. You look for a case and then you vaccinate everybody around. There's a case to be made to vaccinate the whole of the DRC. And I think that could be a good, there could be a good argument for that. And if we could get enough affordable vaccines to be given to the population, that's something we would do. But I think we need to also think about it in the long term, in that for as long as we have a high proportion of the population in Africa that doesn't have smallpox vaccination, the threat of a new variant of Mpox keep continuing to emerge, as we've seen here. First clade 2B and now clade 1B. We need to actually think about in the long term, over the next 5 to 10 years, is to vaccinate the entire young population below 40 of Africa. That's about 1 billion people. So that's not something we're going to do anytime soon. And we're going to need a really cheap vaccine to do that.
I wanted to just show this picture real quick of the vaccines, because you were just talking about it. You can see the Jynneos vaccine. It says right on the label that it's for smallpox as well as for monkeypox. So you can see that on the one on the far right. It says smallpox and monkeypox. This is basically, it's the same vaccine.
This is the vaccine that's produced by Bavarian Nordic, isn't it?
I believe so. Yeah, Bavarian Nordic. It says it on the label right there.
And the reason I mentioned Bavarian Nordic, Professor Karim, is basically because the point that you were making was twofold about availability and cost. Just on the point of availability, we have the soundbite of the CEO of this company, Bavarian Nordic, that produces the vaccine that our viewers that our community just saw, that Armian was showing over there. And he was talking basically about increasing the supply of these vaccines. And I think the claim that he had made was his company can alone produce up to 10 million vaccines up until going into next year, by the end of 2025. But then he says that there is a problem about achieving this target, because firstly, this target sort of has to be set, and that really hasn't been done. Let's just listen to what he has to say, and then I'd like to talk more about what he says.
We are in relatively late August already. So actual fact, we have to make decisions already this week. Do we change gears and start producing Mpox vaccine, or do we continue with some of the other products that we're manufacturing? And every week we don't switch over, we lose some of that capacity that we've been talking about.
Professor Karim, who needs to make that decision that a company like Bavarian Nordic, for example, in this case, should be producing more Mpox vaccines?
Well, I think it needs some clear thinking about what needs to be done. And the first is, are we going to put private interests above the interests of public health? And that, for me, is a much more complex discussion. It's a discussion that failed in COVID-19, where private interests protected themselves and intellectual property on vaccines was retained. And because only a limited number of producers could produce their own vaccines, we had a situation where vaccines weren't available in Africa for quite a while. And we are basically seeing the same thing now, that we are seeing private interests being protected. And in fact, the pandemic treaty is intended to address this very question. And the provisions of the pandemic treaty that were put in that said that intellectual property rights would be suspended or some provisions would be made to enable the wider use of intellectual property for vaccines during a pandemic situation, those were specifically objected to by countries like Germany that want to protect their own industries in this area. If that's the approach we're going to take, then yes, we got to wait for 10 million doses to come from Bavarian Nordic. Then we got to go with a begging bowl and say, please, sir, make me some more. And that's not a way to solve a pandemic. You're never going to solve a pandemic if that's the approach you want to take. What we need is organizations like Gavi and organizations like the WHO to be able, and the WTO, to say that the intellectual property associated with smallpox and Mpox vaccinations, that intellectual property is made available.
So
and then companies that make it cheaply should just do so.
So why isn't the WHO saying it? I mean, they've declared it a public health emergency of international concern. You would imagine that one of the reasons for saying that is that they see that there might be a problem on their hands, on the world's hands. Then, therefore, it follows on that they should be saying what you are saying.
Yeah. I mean, effectively, that's what the WHO has said. Unfortunately, the decision about the intellectual property and the rights over it lie with the WTO. Now, the TRIPS agreement actually makes provision for the suspension of intellectual property rights for public interest in very controlled circumstances. But that's something that the WTO needs to do. That's the World Trade Organization. That's not something the WHO has any control over. If the WHO had control, we'd have everybody making vaccines.
I mean, it's crazy. It's crazy, isn't it, that we're in this situation where you think we would have learnt something following COVID, and yet here we are again with the poorer countries, this time again in Africa, where there are no vaccines. No vaccines have even arrived in the Democratic Republic of Congo, which I just find absolutely astounding. Anyway, I do just need to bring in some of the comments from our chat that have been going on, because we've got lots about the vaccine, also lots about Big Pharma and the money they're making. Joe Anderson makes this point: we never should have stopped smallpox vaccinations. They were stopped, I guess, because it was felt like it wasn't a big issue anymore, and that's why people like me, I think I did get one because I'm old enough, but lots of the people around this table didn't. But you maybe did.
I might have.
You might have,
because we're from that generation.
We're from that generation.
There's a generational divide at the table. Yeah, go on.
But that, I guess, is the reason why. But then what you're saying is that would be the way forward, for example, for the DRC, if you could get the whole population vaccinated. If you could afford it.
So I think one needs to be a bit careful that, hindsight is always 20/20. And, when smallpox was declared eradicated, there was no basis to continue giving the vaccine. And remember, the vaccine was a live vaccine that was given with a bifurcated needle. So it would be a technology we wouldn't even allow today, to be given.
What is a bifurcated needle?
I think that, yeah, I mean, to use a bifurcated needle today. I don't know if you know how we used to give smallpox vaccines, but you basically took the arm, you exposed the skin, you put a drop of the vaccine, you took a bifurcated needle, a needle that looked like this in a V shape, and you poked the skin and you turned it so that the little bit of the drop of the vaccine went under the skin to cause the vaccination. And it would leave a scar.
That's why I've got a scar.
Was important.
We have it so easy nowadays.
That's how you know whether you were vaccinated or not. Yeah. So, I mean, we are talking about a different world, and you don't want to go down that road again. But the same basic approach, which is a vaccinia virus, which is a similar to the smallpox virus, similar to the monkeypox virus. That's what's in the Jynneos vaccine. And those can be made quite cheaply. They're not difficult to make. The problem is we've got to loosen up the provisions on the intellectual property. So don't blame the people who made the wise decision of stopping smallpox vaccine, they couldn't have predicted that that would be the basis, now of Mpox.
And with that, with the smallpox vaccine, there are questions about, is that vaccine the right one? For example, George L. Saying, do we have the right, most effective vaccine right now from the smallpox one? Somebody whose name I can't pronounce, Kona, says, do scientists have, again, say the correct vaccine? And Mijik Osis is saying there's just no stock where it's needed. Well, we've talked about that. There is no stock in the Democratic Republic of Congo yet, although it is supposed to be coming. But is that smallpox vaccine, is it all that's needed? Is it effective for all these different clades that you're talking about?
Yeah, we can't turn back the clock and go back to smallpox vaccination. We need to use newer technology, better vaccines, and right now, Jynneos vaccine, for example, the studies that have been done looking at its efficacy. Remember, its original problem was that it was made, and by the time it was ready, the pandemic of smallpox of Mpox was already receding, so they had difficulty doing a clinical trial. So there have been other ways in which its efficacy has been measured, and the studies show that somewhere between 60, 70%. One study showed 64%, for example. So they're not highly efficacious vaccines, but they're efficacious enough that they actually can slow the spread of this virus. And if you do that, you do have the net effect of basically the pandemic petering out. So what should we be doing? We need better diagnostics. We need a point-of-care diagnostic, not having to go to a lab like we have for COVID. You can just test yourself. For HIV, you just test yourself. We need a rapid diagnostic. And there is one diagnostic that is available, but right now that is licensed, but it's not available, and it's expensive. The second is we need a better vaccine. We need to use our newer technologies. We need to be able to make different kinds of vaccines, and we need to make vaccines that are efficacious. And we have the opportunity to do so now and test them in clinical trials in the DRC in places where Mpox is spreading. And the third, of course, is we need new therapeutics because, as you might have seen, the recent data with ticagrelor are not very impressive. And so we basically don't even have a good therapeutic option for patients with severe Mpox. So right now in Mpox, we need new diagnostics, we get new vaccines, we need the research programs to support them, we need industry to get involved in making them available and making them available cheaply.
We know we have to let you go. So just to sum up, what you're saying is don't panic. This virus doesn't spread the way COVID does, so don't worry about lockdowns and don't worry about travel restrictions. But yes, things need to happen, particularly on the vaccine front and the track and trace front. Is that a good summation of what you were saying?
Superb.
I love making summations. I love making summations. Thanks so much for your time, Professor Karim. We know you have other commitments, so we will let you go. Thanks so much for joining us. Maybe we speak again soon, but hopefully not. Maybe this outbreak is under control by then.
All outbreaks.
All outbreaks. Thanks so much, Professor. Have a good evening.
Optimistic. Thanks, Ganesh.
Thanks so much. Take care.
Bye.
Well, I mean, that's a hopeful message. I mean, to be honest, when I first heard about Mpox, I immediately thought about a vaccine. And then as I looking at this problem, like you're looking at basically a smallpox monkeypox vaccine, but you don't really have them available as such. It's going to be like a special order.
There was also a comment from Nicholas Mikael, how mutatable is 1B? The new variant needs new vaccines. And that's exactly what we were told during COVID, that you need to keep getting a booster because the old vaccine wasn't effective for the new variant. And it's nice to know that there is some kind of effect from the smallpox vaccine, which is a completely different virus, but it still helps people with Mpox.
I mean, there is a vaccine, basically, because with COVID, they had to develop it.
You're right,
in a
it started from scratch.
From scratch. I mean, they used technology that was available for other vaccines, and they incorporated that. But you had to invent a COVID vaccine because that didn't exist. But here you already have one. But as is the case with COVID, it is not getting to the people who need it. But then it's not just about vaccination. It's also about tracking and tracing. those
And
cases.
educating, he said, didn't he, as well?
And educating. But just thinking, because there was a question as well in the community about the mutations and if these mutations and all happen. As we saw with COVID, the moment a variant hit a large population, there was another variant at the end of that transmission chain. So I would imagine the same thing would apply here. You need to be able to try and stop it in its tracks so it doesn't hit another large population and then mutate into something else. And I guess that is where this idea about vaccinating all of the DRC comes into play.
Funnily enough, the one that we were talking about before, the Danish vaccine, which is called Bavaria, although it's not from Bavaria...
You said it.
Whatever it is. What I was reading was that
Bavarian Nordic.
Bavarian Nordic,
yeah.
there we go. That it is not, you can't use it with children, on children. So I think there are lots of complications at the moment, even with the vaccine, let alone getting it. Lots of love, by the way, to the professor. Lots of people saying thank you and great conversation. So that's great that we did manage to get him on.
Yeah, we did want to talk to him for a little longer, but then time commitments. I mean, we are talking about an Mpox vaccine, and he has been involved with this outbreak. Again, just to remind people who were tuning in that he was chairing the Africa CDC meeting that declared this an outbreak, essentially, on the continent of Africa. But yeah, that's the time we had, and that's what we could do with it. But I'm glad that you found this helpful. Let's just bring up the results of the poll that we advertised at the start of this conversation. Cherry has the results for us, hopefully?
Yeah, we have more than 400 votes. Actually, most people, 33%, say that they're, yes, very concerned. I mean, the question is, how concerned are you about Mpox? So 33 says they're very concerned, 25% says they're little concerned, 20% says not concerned, but cautious, and other 20% says they're not concerned at all. I mean, yeah, before we talked, I actually was also very concerned, but then it was actually quite reassuring talking to the professor.
Yeah,
and there's not much of a gap between 33% and 25%, right?
Yeah.
I mean, I would like to think, as Amin and I were discussing at the start of this stream, that our conversation would help you and make up your mind, and hopefully that has happened. But that's it for this conversation this week. We're back again next week with another conversation on a theme that we don't know about.
No, we will know. We'll have a community post up 24 hours before, and we will let you know what we were talking about. A big thank you to Amin, thank you to Cherry, obviously thank you to Biresh, and thank you to all of you for being with us. Great to have you with us. See you next week.
See you next week. Thank you, Alex.